Hi, nice to see you. My name is Takeshi Naito. I'm also
Hello. Nice to meet
colorectal
you.
cancer surgeon and also doing the bariatric surgery.
Yeah.
Dr. Shammer.
Hi.
Hey.
Hi.
Yeah.
How are you guys doing?
Very good. You come on at perfect time.
Hey, I need like 2 minutes. I gotta transfer my slides to my other
problem.
computer.
Take your time. Take your time. It's in, Dr. Sudan is also online. Dr. Sudan.
Hi, Dr. Sudan. So great to see you.
Dr. Sudan,
oh,
hey. Have you seen Dr. Juntao Zhang? Not yet. And also we have Dr. Neto is here. Yeah, Dr. Guo.
welcome. Thank you. Okay.
Great. Let me see.
Dr. Zhang, it's kind of very rare to find a person heading both colorectal as well as bariatric surgery societies in the same country.
Yeah. Dr. Neto and Dr. Zhang, they both.
Both of them?
No. Colleagues.
Yeah. All right. So, Dr. Shower, are you ready, or you need more time? Or
I need just a second. I gotta just transfer.
Okay. Whenever you're ready, we can start. Yeah, that worked.
Okay, great. Now let's see. On the presentation mode here.
Yeah.
Okay.
It's working perfect. Then, okay, let's do a countdown. Let's do a countdown, and we can broadcast to the other platform.
Shall we begin?
Okay, yes, please.
Okay, hello everyone. Good evening. It's my pleasure to meet everyone on tonight's event. This event is one of the Chinese Surgical Continuing Education Week events. And its topic is clinical research and education in metabolic and bariatric surgery. My name is Guowei Jiang. I came from Chinese National Health Commission, Cap City Building and the Continuing Education Center, CBCEC. The CBCEC is affiliated to the National Health Commission. It is a government agency which roles of management and implement in continuing education. By focusing on lifelong medical education, the mission is to improve healthcare professional abilities, to promote homogeneous development of healthcare service in a national scope, and ultimately to protect patients' benefits. The Surgical Experts Commission of CBCEC was formed in December 2019 with 6 committees, including Metabolic and Bariatric Surgery Committee. Since establishing of this professional organization, we have contributed a lot to design and delivery of training courses to the surgeons in China and from abroad. Tonight's webinar is focused on the clinical research and education in metabolic and bariatric surgery. We invited the former president of the American Society of Metabolic and Bariatric Surgery, Dr. Philip Schauer, the current president of the Association of Surgical Education, Dr. Renjian Sudan, and Dr. Li Mengyi from Capital Medical University, Beijing Friendship Hospital, to give speeches on clinical research in metabolic and bariatric surgery, training and education in metabolic and bariatric surgery, as well as clinical data management. In addition, professors from China, Japan, and India will join the panel discussion. I wish everyone can benefit from tonight's webinar. Now, I will invite the webinar chair, Dr. Zhang Zhongtao, to give a welcome address. Dr. Zhang is the Vice President of Capital Medical University Beijing Friendship Hospital and the Chair of the Department of Surgery. Please, Dr. Zhang.
Okay, thank you. Good evening, everyone. Welcome to the international webinar on research and education in metabolic and bariatric surgery. This webinar is organized by Chinese College of Metabolic and Bariatric Surgeons. It's a national academic organization affiliated to International Health Commission. Its main missions include training, accreditation, and quality improvement in China. I'm Dr. Zhongtao Zhang, President of this organization and the Chair of General Surgery in Beijing Friendship Hospital of Capital Medical University. As we know, obesity has become a global crisis that affects more than 650 million people worldwide. Metabolic and bariatric surgery is an effective treatment modality for this pandemic. However, awareness of obesity and metabolic and bariatric surgery is still not adequate among our patients, healthcare providers, policy makers, and social workers. Currently, only less than 1% of qualified patients has access to metabolic and bariatric surgery, meaning that this specialty has huge potentials in the coming years. We still have a lot unknown that need to be figured out by research, and we still have high demand in bariatric surgery training, surgeon training, because our patients deserve high quality care. Today's webinar will focus on clinical research, training, and the patient data management. I believe this webinar will not only benefit you as a bariatric surgeon, but also benefit your patients by receiving evidence-based treatment. Today's webinar is broadcasted live on multiple online platforms. Thanks to every faculty for your participation, and to Panther Healthcare for the sponsorship. I'm looking forward to working together to deliver a successful webinar. Thank you.
Thanks for Dr. Zhang's welcome address. Now I will invite the other moderator, Professor Peng Charles Zhang. Charles is currently the Chief of Metabolic and Bariatric Surgery in Beijing Friendship Hospital of Capital Medical University. He is one of the leading academic bariatric surgeons in China. Besides clinical works, he also has strong research and publication records and hosts many educational events. Dr. Zhang is Executive Council member of different national academic organizations and associations. Please, Dr. Charles Zhang.
Thank you so much, Dr. Guo, and also thanks Dr. Zhongtao Zhang for the welcome address. So now we come back to our sessions. Going to invite first speaker, Dr. Phil Shower. Dr. Shower is from Pennington Biomedical Research Center in the Louisiana State University from United States. We have three discussants. One is Dr. Takeshi Naito from Kitasato University in Tokyo, Japan, and Dr. Vivek Bindal from India, New Delhi, from Sir Ganga Ram Hospital. And also we have Dr. Stephen Yao from Fudan University, Huashan Hospital in Shanghai, China. So the first talk going to be presented by Dr. Phil Shower. His topic is clinical research in metabolic and bariatric surgery. Welcome. Please, Dr. Shower.
Thank you, Dr. Zhang. It is certainly a pleasure to participate in this international forum on research for metabolic surgery. I'm very honored to be here, and I'd also like to thank all of the organizers and the Panther Medical Corporation for supporting this program. So, so I'm currently at the Pennington Biomedical Research Center after 15 years at the Cleveland Clinic. I was recruited to this wonderful research center in Baton Rouge, Louisiana. And by surrounding myself with 500 scientists who focus on obesity and diabetes, I hope to continue to make some contributions in this area. My email is here, and also please follow me on Twitter too, at pshowermd.
Excuse me, Professor Shower, could you please share your screen for us? Share your screen.
Okay, I believe I am. No, let's see. Oh, okay.
Okay, thank you.
Thank you very much.
You're welcome.
Okay.
Okay.
Okay, how's that? Okay, very good.
That's great. Very good.
Okay, very good. Sorry about that. Yeah, so this is where I am currently at the Pennington Biomedical Research Center. Please come by and visit us sometime. These are my disclosures. I don't think any of these have any particular conflicts with the presentation. So what is the goal of clinical investigation? Well, I think it's really to develop a consensus on the value of a medical treatment or intervention based on the scientific evidence in order to incorporate this treatment into widespread clinical practice. So it all begins with clinical observation. I just want to share with you a real brief clinical vignette. This is a patient of mine back in 2009 who had type 2 diabetes and obesity, and she was poorly controlled on medications, and she underwent Roux-en-Y gastric bypass. And over the course of 10 years, this is what happened to her body mass index. It dropped from just below 40 to about 25, so her weight became normal. But most important, her A1C, which was above 10, dropped below 6 and maintained a level of below 6 for essentially 10 years. So here she is before, and here she is 10 years later. And so obviously a dramatic result. So the question is, this is one case. Is her result typical, or is her result an outlier? And how strong is the evidence of this intervention, metabolic surgery, at treating and resolving type 2 diabetes? So it all comes down to addressing what we all know is the priority or weight of evidence. And evidence can be categorized essentially into 5 categories. Very high quality evidence, which generally consists of multiple well-conducted randomized controlled trials. Level 2 are randomized controlled trials of lesser quality or perhaps prospective non-randomized studies. Then level 3 are case-controlled or what we call matching cohort studies that are generally retrospective analyses. Level 4 is a case series, essentially a before and after type of study. And then finally, the lowest level evidence is expert opinion. So this is what we have to deal with. And the higher the evidence, obviously, the greater probability that we can predict the result of a given treatment. So let's go through some examples. Case series, evidence level number 4. So this is where I got interested in metabolic surgery more than 20 years ago. And this was one of my first publications in Annals of Surgery back in 2003. And this was a case series where we evaluated nearly 200 patients who had type 2 diabetes and severe obesity. The average BMI was about 50. And we followed them up to 54 months. And we found that the weight loss was remarkable, an average of 60% excess body weight loss. And about 83% of the patients reduced their hemoglobin A1C to normal levels. And the remainder had significant improvement, okay? So this is essentially what we would call a case series. One intervention, before and after results, and notice there's no comparison. So you have to ask yourself, well, how does this treatment compare to another treatment? So this is important information because it generates a hypothesis for further investigation. So next we have retrospective comparative studies or cohort studies. This is level 3. Now in the field of metabolic surgery, we have quite an abundant number of comparative observational studies. And here is a recent summary from Dr. Aminian and Dr. Steve Nissen, my former colleagues at the Cleveland Clinic. And in our field, there are now 28 comparative studies going back to 1997, where patients who had surgery are matched for key demographic features to patients who did not have surgery. And some of these are published in high-impact journals like the Journal of the American Medical Association, New England Journal of Medicine, Lancet, Diabetes Care, Gastroenterology. Now, they're all quite remarkable in that all of them, 100%, show a mortality benefit for metabolic surgery. That is, surgery compared to the non-operated control group results in a reduction in mortality over time, averaging about a 45% mortality reduction, which is quite significant, much more than what we see with any other type of treatment. However, these are not randomized controlled trials, and are subject to some of the limitations, some of the inherent problems with randomized controlled trials. Now, interesting, most of these studies, in their conclusions, they recommend or suggest that we need randomized controlled trials to verify the findings, to validate the findings. Now, let me share with you an example of one of these comparative observational studies that I was involved with the first author, Dr. Ali Aminian, my colleague at the Cleveland Clinic. And this study was just published last year in JAMA in September 2019. It's a good example of a comparative observational study. So in this study, over 2,000 patients who had metabolic surgery at the Cleveland Clinic, and this is during the time, the 15 years that I was at the Cleveland Clinic, 2,287 patients with type 2 diabetes underwent metabolic surgery, mostly the Roux-en-Y gastric bypass. Now, these patients were matched in a 1-to-5 ratio with patients who were similar in terms of diabetes, age, body mass index, but who did not have surgery during that time period. And then we looked at the results over an 8-year period to determine event rates such as death, heart attack, and stroke. And this is what we found. We found that metabolic surgery was associated with a significant reduction in death, new onset heart failure, new onset coronary artery disease, stroke, decrease in nephropathy, and decrease in atrial fibrillation. So a fairly remarkable reduction in these important clinical events. The number needed to treat to see a mortality benefit was 13, which is actually a pretty impressive number needed to treat for any medical therapy. Now, the conclusion of this study in JAMA was that this observational study must be confirmed with randomized controlled trials. Okay? So, that's level 3. Level 2 is a prospective comparative study. Let me show you an example of that. The SOS study is a prospective but non-randomized trial. And everybody in the field of metabolic surgery is, of course, familiar with the Swedish obesity subject study. Approximately 2,000 patients who had some type of bariatric surgery back in the 1980s were matched with about 2,000 patients who did not have surgery. And they were matched with about 18 different demographic features, such as age, body mass index, comorbidities, and so forth. And you can see here the results in terms of weight loss, showing that all the types of bariatric surgery, the banding operations, gastric bypass were superior in terms of weight loss. And then additional studies showed that bariatric surgery reduced these major events such as heart attack, stroke, death, microvascular complications. So this is an example of a level 2. Now, it's important to understand that these observational studies have limitations, and should we trust them to make important decisions in caring for our patients? And here's a nice article by my mentor, Dr. Steve Nissen, who was the former chair of cardiology at the Cleveland Clinic, pointing out that the randomized controlled trials are the most reliable source of evidence because they leverage the power of randomization to ensure that both comparative groups are equal in terms of the known factors that may influence the outcome, as well as the unknown factors, the so-called confounding variables, okay? observational studies alone do not prove causation. They are very useful in generating hypotheses, but they are not adequate in terms of demonstrating or validating clinical results. And here's just a nice table. I won't go into detail here because of the time, but the strengths and weaknesses of randomized controlled trials versus observational studies. The challenges, of course, with randomized controlled trials that they are very expensive, they're difficult to conduct, they take a long time to perform, and the randomization process is quite challenging. That is, to identify patients who are willing to be randomized to one treatment or another. That's particularly challenging. Now, in metabolic surgery, do we have prospective randomized controlled trials? Well, the answer is yes. And let me show you an example of a study I was involved with. This is the Stampede trial, which has been published 3 times in the New England Journal of Medicine, most recently in 2017. This is a randomized controlled trial of 150 patients who were randomized to either intensive medical therapy for type 2 diabetes, gastric bypass, or sleeve gastrectomy. And this shows you the treatment arms here. This is the medical therapy group with fairly intensive medical treatments with drug therapy and lifestyle intervention with the intent to reduce the A1C to 6% or less. The other arm was the Roux-en-Y gastric bypass, and then the other arm was the sleeve gastrectomy. So 150 patients were randomized to one of these 3 treatment arms. And the primary endpoint was to determine changes in A1C. And this graph shows you the differences or changes in hemoglobin A1C over the 5 years of this trial. And you can see that those patients who received medical treatment did have a significant improvement compared to baseline A1C initially. And this improvement actually peaked at the 6 to 12 month period. But notice that over the 5-year period, despite adding more medications, the A1C drifted back toward the baseline, whereas both surgical procedures, the bypass and sleeve gastrectomy, had a much greater reduction in A1C that was much better sustained out to the 5-year period, such that compared to baseline, those patients who had surgery, most of them were much better off prior to the study compared to those who had medical therapy, whereas many of them were unchanged or in fact even worse off despite the fact that they had more intensive medical therapy. Okay. Now, today in 2020, we have multiple randomized controlled trials like the Stampede trial. In fact, here's a summary of 12 other randomized controlled trials comparing various types of metabolic surgery, gastric banding, gastric bypass, sleeve gastrectomy, with medical treatment for type 2 diabetes. And as you can see in the far right column, essentially all of these studies, with one exception, have statistically significant difference in A1C improvement or remission in the surgical group compared to the medical group. The one outlier is the study third from the bottom by Ding and others, and this was a study comparing gastric banding with medical treatment, and that did not show a significant difference. So we now have 12 randomized controlled trials, but here's an important point. These studies looked at biomarkers as endpoints, okay? So when you're looking at a trial, it's important to look at what the endpoints are, because biomarkers are surrogate markers of disease compared to clinical endpoints like myocardial infarction, stroke, and death. Okay, so while we have 12 randomized controlled trials with biomarkers as endpoints, what's really important is what is the effect of metabolic surgery on these hard clinical endpoints such as heart attack, stroke, and death. So that type of trial is called a cardiovascular outcome trial, where we are specifically looking at these clinical endpoints of disease: heart attack, stroke, death, revascularization, amputation. These are examples of endpoints of cardiovascular outcome trials. Now, let me ask you, how many cardiovascular outcome trials have been conducted in the 70-year history of metabolic and bariatric surgery? And here's the answer. The review of the literature shows 0. That's right. There are 0 cardiovascular outcome trials in the 70-year history for metabolic surgery. Now, I suggest that conducting a cardiovascular outcome trial in our field is critically important so we can definitively answer 2 questions. Question 1, does metabolic surgery actually reduce morbidity and mortality? Not does it just improve blood sugar, but does it actually reduce morbidity and mortality of diabetes? Then the second question is perhaps even more profound, and that is, does weight loss, and we know weight loss is at least one of the key drivers of improvement in diabetes, does weight loss itself improve morbidity and mortality? And there's never been a study showing that weight loss by itself actually reduces morbidity and mortality. So why do we need a cardiovascular outcome trial? Well, as I pointed out, observational studies are prone to error. Current observational studies really have not changed the practice. Dr. Zhang, at the outset of this forum, pointed out that only 1% of people who are eligible for bariatric surgery are actually getting bariatric surgery. And why is that? Well, perhaps because our evidence is not strong enough. Randomized controlled trial is the standard for any treatment of diabetes with cardiovascular endpoints. This is true for both medical treatments and surgical treatments. Now, conducting a randomized controlled trial for surgical intervention is much more difficult, but it's possible. Did you know that there are more than 100 cardiovascular outcome trials for coronary artery bypass? Yet there are 0 for metabolic surgery. This is important. It's important for patients, for physicians, for the payers, the individuals who are actually paying for surgery, whether it be a government or a private insurance. But I submit to you that such a trial is feasible. We have examples of these being conducted. I mentioned coronary artery bypass surgery. And we've also shown that 12 small randomized controlled trials in metabolic surgery have already been successfully conducted. So what would such a trial look like? Well, let me conclude by saying this would be my dream trial for a cardiovascular outcome trial, okay? So diabetes reduces effectively after medication or metabolic surgery, the DREAMS trial. And right now, I, along with many colleagues and experts in the field, are trying to put together a trial either conducted in the United States or perhaps internationally to help answer this important question. So, and the trial is called DREAMS, D-R-E-A-M-M-S. So thank you very much for your attention. I look forward to hearing the other speakers in this very interesting forum. Thank you very much.
All right, thank you so much, Dr. Shower. This very, very great presentation about clinical research and your personal experience in the research. And we have a few discussants, including Dr. Takesh, Vivek Bindal, and Stephen Yao, and also invite guest faculty. Lucy Huang is our chair of cardiology, and can join us for discussion. Dr. Neto, have any comments?
Yeah. Well, it's a very nice, very attractive present, and actually congratulations. I really envy your situation that you can do that such a big research project regarding metabolic surgery. Well, actually, we all know that the meta-analysis of the LCTs is the highest evidence level. But it is also true that to conduct such a big study is very difficult because of the funding problem. Also, if there is a big difference between the control arm and then the surgery arm, there's sometimes there might be a ethical problem between these two groups to do the LCTs. So yeah, anyway, congratulations. It's very nice. Thank you very much.
Thank you. You know, I think you raised a very important point. These large randomized controlled trials with clinical endpoints are very challenging. You need a large number of patients. You need sometimes thousands of patients as opposed to a much smaller number. They are difficult to conduct. There are ethical issues. However, as a cardiologist, you know that for any treatment that claims a cardiovascular benefit, the cardiologists, they want a randomized controlled trial, right? Whether it's a medical treatment or whether it's a surgical procedure like coronary bypass or, carotid stenting, or, coronary artery stenting, because the confounding variables are so significant in an observational study, you really need a definitive trial. They're expensive. In the United States, we are spending right now $7 billion per year on metabolic surgery. Yet we have 0 cardiovascular outcome trials.
Yeah.
I think, Dr. Shower, that was an excellent presentation, and all of us know the kind of research you have done has actually made the path for others to follow in pediatrics and has impacted the clinical practice world over. So I think most of us have been doing observational studies, as you rightly mentioned, and we are doing case control studies. So people who want to now switch to randomized controlled trials, what will be your tips? Because it is always said that in surgery, it's very difficult to convince the patient that on the drop of a hat, it will be decided whether you undergo treatment A or treatment B. So you have had a very successful Stampede trial. How did you convince your patients to register for the trial, and how would you try to give some more tips for people who want to do a RCT?
Yeah, that's a very good question. And I think you bring up this issue of what we call equipoise, okay? And that is, to justify a randomized controlled trial, you have to propose a question that you don't know the answer, okay? So back in 2005, when we designed the Stampede trial, at that time, there were no randomized trials comparing metabolic surgery with intensive medical therapy. So we really could not tell patients which one was superior. So we felt that there was equipoise. So patients would be motivated to enter the study knowing that regardless of whether they were randomized to surgery or to medical therapy, they were likely going to have improved care over what they were receiving before. So I think that's an important factor to consider. And what attracts patients to these studies is that by entering such a study, they're going to either get surgical therapy, which would likely improve their diabetes, or more intensive medical therapy. So that's important when you design your study, that you're providing the patient something better than what they're currently receiving.
Yeah, I think that's a very valid point. And actually, we took a leaf out of your Stampede trial, tried to reconstruct it in our own setting, and involve the endocrinology department in our institute, do some hormone levels, and do some also involve microbiology for the gut biota. But we did not see that kind of motivation from the medical colleagues, and actually that was the problem when we could not randomize it. So it ended up being a case control study, because they were somehow convinced that these patients are, a specific subset will definitely do better with surgery and the other subset will definitely do better with medical treatment. So to have that equipoise in both physicians and surgeons, and to find a kind of common platform where both agree, I think it's a difficult feat to achieve, which you have.
It's a challenge. Yeah, the recruitment is one of the most difficult pieces. For Stampede to recruit 150 patients, we had to screen several thousand patients, you see. So you have to find, not everybody wants to be part of a trial. Not everybody is willing to be randomized. And it's so important that you have patients that once they are randomized, that they will follow that treatment, okay? So you have to go through a huge process of screening a much larger number of patients to get to your endpoint. And that's why having, a registry or electronic medical record that will allow you to screen large numbers of patients to identify ones that meet your inclusion criteria and are willing to be randomized. It's a challenge.
All right, thank you. We also have Dr. Lucy Huang. He's our chair of cardiology. Dr. Huang, you have any comments on Dr. Shower's DREAM trial, cardiovascular outcome trial?
I think it's amazing that after procedure, including the blood pressure, BMI, also the lipid level is reduction about 45%. I think versus the baseline. So I just wondered if the body, the BMI, if the BMI is reduced, do you think we still need the medication treatment about to control the blood pressure, also the diabetes, the glucose level? How do you think the procedure and the medical treatment?
That's a great question. Yeah, I think the question related to medical treatment in the surgical patient, in our Stampede trial, once the patients start losing weight, their blood sugar starts to improve, their blood pressure starts to improve, their lipids improved.
Yeah.
So we necessarily had to reduce their medications, especially the the blood sugar lowering agents because we were fearful of hypoglycemia. The same with antihypertensive agents. We had to reduce them because we feared that their blood pressure would get too low. So in the surgical group, you really have to lower them to a certain degree. Now, there are certain drugs, for example, like statins. There are many cardiologists that believe, statins have many other benefits other than just lowering the lipids. So it may be, valuable to keep patients on a statin, even though their lipid levels are near normal. So I do think that you made a very important point here, and that some of these issues of how you manage the medications in the surgical group still need further delineation.
Mm-hmm. One more question. In your, observational study, do you have the case, maybe some cases, to just stop, including starting, stop every medication treatment? Is there any way?
Can you say that again?
Is there any case to stop any medication? To stop, to take statin, to take other, maybe beta blocker, CCB, like that?
You mean after surgery, right?
Yes.
Yes.
After surgery.
Yeah. As I mentioned, there are certain situations where you must, because if a patient's A1C drops to 6% after surgery, you definitely want to take them off of some of the blood sugar lowering agents. But also you point out, metformin. Metformin may have benefits other than lowering blood sugar. And same with the GLP-1 and SGLT2. However, those drugs do lower blood sugar significantly. So you have to be careful if you maintain those drugs, the consequences of hypoglycemia.
Okay, thank you.
Good. Stephen, are you here? All right, so before we move to the next speaker, have another question for Dr. Schauer. Now, what do you think about real world study? For our, I don't see any of study relate to the real world. What's your opinion about that real world study?
Yeah. That term real world study can mean a lot of different things, right? For example, the biggest challenge in these types of studies for patients with diabetes is what medical treatment are they going to get, right? And there's a spectrum from what we see in the community, okay? In the United States, for example, many patients, perhaps most, are not on a GLP-1 agonist. They're not on an SGLT2 inhibitor, okay? Even though there are many trials that suggest that they should be on that. But the reality is, maybe because of cost, many are not on those drugs. So that's one edge of the spectrum. And then going all the way to the ideal. The ideal would be a treatment such as my colleague Ricardo Cohen from Brazil. He just published a small randomized controlled trial comparing best medical therapy and metabolic surgery, looking at renal function as the endpoint. And the medical group there, all the patients were on a GLP-1 and an SGLT2 inhibitor, and on average, eight different drugs. Okay, so that would be an ideal study, but that study would be impractical in the real world because of cost and ability for patients to take all those medications. So when you say real world, is what is reasonable to expect in terms of patients in the real world, in a community setting to receive. And so we tried to set up our Stampede trial to be more real world, even though it was intensive. Most of the patients were on a GLP-1, but not all of them. And not all of them were receiving, ideal blood pressure, ideal blood sugar, and ideal lipid control. So I think the real world studies really are important as well.
All right, great. So thank you so much, Dr. Shower. Let's now move to next speaker, Dr. Ranjan Sudan. Dr. Ranjan Sudan is the professor of surgery from Duke University Medical Center in the United States. And he's also the current president of Association for Surgical Education. And he's going to talk about training and education in metabolic and bariatric surgery. Please, Dr. Sudan.
Thank you. I'm trying to share my screen.
Yeah, you are sharing your screen now.
Okay, great. Can you see well?
Yeah, I see your last page of your slide.
There we go. I'm going to see if I can just go to slideshow.
From beginning?
Yeah.
Yeah. Yeah, that one.
Okay.
Yeah.
All right. Am I at the beginning right now? Because for some reason it's not cooperating on my thing, but can you see the first slide?
I see your last slide.
Okay, let me see if I can just relaunch this.
Okay.
For some reason, I was having just a little bit. Okay, let's try this again.
Okay, share screen.
How's that?
Yeah, worked. Perfect.
Okay. Yeah, I might be on not presentation view. I'm going to try once to go to slideshow, but if that doesn't work, I'll just stay on this one.
That's fine.
Yeah, it just looks like it just wants to stay there. Well, thank you so much, Charles. It's very good to see many friends, and I hope that we resolve all of this pandemic situation so that we are able to visit with each other in person again. Certainly, thank you to the Panther Corporation for also facilitating this process. And I'm seeing many international friends, including Dr. Shower, who is one of our actually very first trainees at Duke. He did his fellowship at Duke, and I know that he thinks very fondly of that. And so I think education and training is really very critical to helping people achieve excellence in their field. So what I'm going to do is talk about the outline, which is the overall structure of the bariatric fellowships in the US. We'll talk about some of the requirements that are in place to be able to complete a certified bariatric fellowship. Mention a little bit about how to evaluate bariatric fellows and make sure that they're progressing nicely, and then just talk about a few of the developments that are new in the field of surgical education that are also being incorporated in bariatric surgery. So, we hope to be able to go through this over the next 10-15 minutes. So the way the bariatric fellowships are governed, there's two different systems in the US. One is the Accreditation Council for Graduate Medical Education, which is the ACGME. And the ACGME puts a lot of rules and regulations in place for how to run a training program. Not all training programs are accredited by the ACGME. So there's a number of different programs that are actually governed by the Fellowship Council, which is a sister organization. It doesn't have quite the extensive infrastructure and requirements in place like the ACGME, but meets the needs of many different training programs, such as transplant, HPB fellowships, bariatric fellowships, MIS, and then so several of these fellowships, including some colorectal fellowships, fall under the umbrella of the Fellowship Council. And the Fellowship Council typically runs a match, and this match is eligible to surgical applicants who have completed their surgical training, typically a US surgical training, which is 5 to 7 years in length, and are board eligible. So these people, by the time they graduate, they've been certified by their program directors that they're able to practice general surgery independently, not necessarily MIS surgery, but certainly general surgery. And the match takes place in the 4th year of their residency training. And the bariatric surgery fellowship is really 1 year after they have completed their surgery training. The requirements for the training are really set forth by the American Society for Metabolic and Bariatric Surgery, and they have a subcommittee called the Bariatric Surgery Training Committee that actually has come up with the curriculum and a lot of the evaluation systems, etc. So there is a formal process in place. So taking it from the ground up, the Bariatric Surgery Training Committee helps design the curriculum. It gets approved by the ASMBS. The ASMBS then proposes it to the Fellowship Council and is accepted by the Fellowship Council. And thereafter, the Fellowship Council really helps conduct the match and takes prospective applicants and gets them matched to suitable fellowship positions. So what's the purpose of training? The purpose of training is really to provide comprehensive, state-of-the-art medical and surgical training in morbid obesity and obesity-related diseases. And in general, the education is divided into units, and I'll talk about these units. It's understanding what morbid obesity is about, the non-operative management of morbid obesity, the primary operative management. These are talking about primary operative cases, revisional operative management, also how to manage complications, and then there's how to run a bariatric program. So these are the various components of a fellowship training. The cognitive part of it, which is the didactic part of it, covers these 18 topics. I won't go through all of them, but if you look at my previous slide, it really goes through the medical, the surgical part of the primary, as well as the revisional process. And it also talks about endoscopy, as well as managing post-operative complications and nutritional deficiencies. And now that obesity is becoming more of a childhood problem as well, there's also a section on obesity in childhood and adolescence. So the way the traditional fellowships are designed, these are one-year fellowships, which basically means they are time-based, but they've also introduced some case requirements. And the case requirements are that the fellows should have done at least 50 stapling or anastomotic cases in which they can say that they have done more than half the case. So for more than half the case, maybe 51% of the case, they are the primary surgeons. And so they would have, if they've done 51 such cases, they would meet the case requirement. But there are some additional requirements, such as they cannot count only sleeves, for instance, to meet all of these case requirements. They have to do these stapling cases. They have to do at least 5 revision cases, which is really not much, but at least it introduces them to revision surgery. And then in addition, they have to have done preoperative evaluation of about 50 patients. And then they must follow these patients so that they're just not in the operating room. They're also seeing patients postoperatively in both the clinic as well as the inpatient setting. Most of these have to be done using minimally invasive techniques. I think the vast majority of fellowships are now MIS fellowships. It used to be that they were primarily open bariatric surgeons, but that has more or less disappeared. There's also the requirement that they would have attended at least one support group meeting so they know what that support group is all about, as well as one education seminar where patients are educated about the various pros and cons of the different types of operations. So now, how do you evaluate the fellowship trainees? I think that's important because they don't want to be just there completing the 1 year and doing the cases. You want to be able to make sure that you're evaluating them properly. So the traditional system has been time-based, but now more and more we are talking about competency-based evaluations. And competency-based evaluations are typically more in real time. So when a trainee is operating, you give them a sense of how they're operating, what their pros and cons are. And the same thing with medical management or cognitive expertise. So if they're not doing well, then they sort of don't progress to the next stage. But if they're doing well, then they progress to the next stage. So that is more competency-based. And the goal is that by the time they've completed their fellowship in 1 year, that they would have actually achieved all of these competencies that are defined. So these competencies that were defined really came from the Accreditation Council of Graduate Medical Education. And they're not just looking at whether you can pass a test, but they're looking a lot for, can you take good care of your patients? Do you have good medical knowledge? Can you continuously learn? Do you communicate well? And can you work professionally in a team-based environment, etc.? So, these are all the ACGME competencies where people are paying attention not just to your skill as a surgeon or your medical knowledge, but also how do you interact as a human being in the environment that you live in, which is the hospital system and a multidisciplinary approach. The newer system now is actually to go to a milestones approach, and this is the milestones. So the milestones approach, there we go, we're finally in the presentation mode. So the milestones approach really puts people at 4 different levels, and they can be for all domains. So you can imagine that you're looking at them, say, for interprofessional activities, or you're looking at them for skills, technical skills or medical knowledge. You can go through all of these, and this is just an example of how you evaluate communication. And what they do is this, in medical education language, is just called anchors. So level 1, they describe what the anchor is, and they say this resident basically communicates at a, more at a PGY1 level or a first-year trainee level, whereas when you're practicing at a level 4, then this is at a very high level, which is the resident is capable of leadership when adverse events occur. And so this is sort of the way the milestones are described, and all trainees have to go through this milestone approach in residency training, and now we are incorporating the same milestone approach in bariatric surgery training. There is yet another concept that has become very popular, and that is the EPA concept, or the Entrustable Professional Activity concept. And this was really proposed by a doctor in Europe called Olli Tenkati. And what he did, he's an anesthesiologist, and what he did was he took simple tasks such as endotracheal intubation, and more complex tasks such as maybe double lung insufflation, etc., for thoracic cases. And he said, we'll break these down into activities where they are very discrete, whereas the competencies are not very discrete, the EPAs are very discrete. And so if you've completed an EPA successfully, then we'll certify you as being capable of doing these on your own. For instance, we can in bariatric surgery say that one of the EPAs is that you will do a sleeve gastrectomy on your own. So once a trainee can do a sleeve gastrectomy by themselves without attending supervision and has done a number of them successfully, then we can say that they have achieved this EPA where we can entrust them to do a sleeve on their own. So we've actually started developing bariatric EPAs through the Bariatric Training Committee, and these EPAs are scored on a level 1 through 5. So if somebody cannot do the task at all, they would be at a level 1, which is a complete failure to perform a task. Whereas if they can do this very expertly, then they would be at a level 5. So when you evaluate them, these are kind of the principles that are used, or the grounding sort of indicators that you use. So perform tasks independently is a level 4, and before a fellow graduates, they need to at least be on a level 4 where they can able to perform these tasks independently. And so there's a number of EPAs that have been defined both for patient evaluation as well as technical skills and postoperative management and management of complications, etc. And so we are required to complete these evaluations for our fellows. How do you evaluate technical skills? These are sometimes hard to define. Fortunately, there's been some research that's been done. So the methodology that is used is called the Global Operative Assessment of Laparoscopic Skills, or GOLS, and this can actually be used to provide more in-depth feedback on the technical skills of a fellow. This was originally developed in McGill University in Canada, and it was based on the objective structured assessment of technical skills, which was primarily for open surgeries. And here the rating is on a 5-point global rating scale, and they've got descriptive anchors at 1, 3, and 5. 5 is at the expert level, and 1 is at the very basic level. 3 is, you know, as you would expect somebody to perform at their level of training. And the items that are included here are how well do you perceive depth, how well do you use both your hands, how efficient you are with completing the tasks, how gentle you are with tissue handling. And autonomy basically implies that you can do these tasks on your own without too much guidance. And so these items are used to assess a fellow's technical skills. A minimum of 4 such evaluations are required in a year for us to be able to certify a fellow. And so we periodically, over the course of the year, will do this. So we've not gone to a completely competency-based system. In a true competency-based system, if somebody achieved their competencies in 6 months, they'd be ready to graduate. And if they didn't achieve it in 1 year, then they might need to stay some extra time and do this in a year and a half or 2 or whatever time it took them to complete it. But we are not in that strict competency-based system. We are in a time-based system, but within that time-based system, we are incorporating some of these competency-based education principles. So if somebody is lagging behind, you know, they can certainly go back and to the simulation lab and practice their fundamentals of laparoscopic surgery skill and FVS, which is the fundamentals of endoscopic surgery skills. These skills and these tests are actually required to be completed before a training can sit for the American Board of Surgery exam. So a lot of our trainees come with at least some degree of basic knowledge, both in laparoscopic surgery as well as in endoscopic interventions. Because there is more and more general surgery that's being done laparoscopically, the trainees will come with a fair amount of experience, maybe with laparoscopic hernia repair or laparoscopic cholecystectomies, maybe some Nissen fundoplications, but they don't have quite the degree of experience, perhaps in suturing laparoscopically. And now even the robot is becoming more popular. So they don't have those types of skills. And so that's really what we focus on in terms of developing technical skills, which is taking them to the next level as far as their bariatric surgery skills are concerned. But training doesn't stop after you've completed your fellowship. Training continues even into graduation. You can attend workshops, you can attend professional seminars. When I trained in bariatric surgery, it was only being performed open, so that's the only way I knew how to do it. All of my laparoscopic training and my robot training was acquired as a junior faculty member, and I attended professional courses at the Bariatric Society and attended workshops and cadaver courses, etc. And then did some visiting observerships where I saw surgeons who were technically past their learning curve, see how they did these operations, and then basically did some more proctored cases. And these will, as we come up with new techniques, as we come up with new advances, these will continue to be in place. And so, training doesn't stop the day you complete your fellowship. Training continues, and it's pretty much a lifelong activity. And that's what we really want to be able to encourage, is an environment of lifelong learning. So in conclusion, what you really need is a systematic approach to training. It has to have a well-designed curriculum. The curriculum has to be both cognitive, which means essentially medical knowledge, and skills. And then you have to have a suitable evaluation system so that you are evaluating these to establish a quality education program. In addition to cognitive and technical skills, we also need to make sure that people are professional, that they are treating each other well, that they know how to work in a multidisciplinary team, and they are engaged in this lifelong learning, and they are constantly improving themselves over a period of time. So the current trend is to move towards a competency-based training model using milestones and EPAs and rely less on case numbers and time duration. We are still a little bit tied to case numbers as well as the time, like I mentioned, but I think more and more people are wanting to go to these milestones and EPAs. And now we are using certain apps that help us put this information more in real time for our trainees. And so with that, I'm going to conclude and thank you. And I'm going to stop sharing my screen. I'm happy to answer any questions and engage in any discussion.
All right, thank you so much, Dr. Sudan. So Dr. Neto, do you have any comments? What's the training system in Japan?
Well, yeah, thank you very much. I have two questions. And the one is about the number of the case requirement of the training system of the bariatric surgery. Is this number it should be involved as a surgeon, operator? I mean, or is it counted if the trainee get into surgery? I mean, scrub in, just scrub in. Is that counted?
Yeah. So just scrubbing in, you can count that as a case, but you can't count that as you being the primary surgeon. So to count it as a primary surgeon, you have to have performed actually more than 50% of the case. So if you've done 51% of the case, then you can count that as a primary surgeon, but not if you've only scrubbed in. And so one must have at least 51 such cases. Now, it's arbitrary because some people may come with very good skills and they may be able to learn very quickly, but others may take much longer to develop their skills. I think some of this work might actually have been grounded in the original work that Dr. Schauer did, and maybe Phil has a comment. I think one of his papers showed that you needed at least around 75 cases or so to be able to overcome your learning curve to do cases. So now that the expert surgeons have overcome their learning and the trainees are coming actually with better laparoscopic skills. That's how they've sort of arbitrarily defined that if you can do 50 cases as a primary surgeon, then you'll qualify to be a bariatric surgeon, have completed a bariatric fellowship. But you actually have had to have performed those cases for the most part as a primary surgeon.
Okay, thank you very much. And also, in the United States, is bariatric training considered as a same level as a other abdominal surgery like gastric surgery or colorectal surgery, or
right.
The basic or the bariatric surgery training should be done after finishing the basic training? What is the situation?
So residents during their general surgery residency will get some bariatric surgery training depending on which medical center you are at and how they are set up. But currently the bariatric training is post-surgery residency. So the residents have completed a full general surgery residency. And it is only after that that they go into the bariatric surgery fellowship. So it is kind of like an advanced training. Now, even though it's advanced training, it is not fully regarded with an independent certification by the American Board of Surgery, but they're working towards that. So people will be able to get what's called added qualification in bariatric surgery. And I think that will happen soon. So we are moving towards that to where it's counted almost like you've done additional fellowship training in vascular surgery, or you've done additional training in cardiac surgery. It's still not quite to that same level. It's going to be more at the level of surgical oncology. So the surgical oncologists recently got a additional qualification certificate approved by the American Board of Surgery. And so similarly, bariatric surgery is moving in that direction.
Okay, thank you very much.
All right, thank you. I see Stephen Yao. Dr. Stephen Yao is online now. So Stephen, what do you think, what are we missing for the bariatric training in China?
Hi, Dr. Shudan, nice to see you again.
Good to see you too.
Welcome to Shanghai again.
Thank you.
I have another question. In the US, I believe some GI surgeon want to convert to the bariatric surgeon. Is there any necessary to follow the training of bariatric fellowship or pass the examination?
No, at the moment it's not a requirement because many of us actually started that way, where we were primarily general surgeons, and then we drifted either from our own interest, our practice patterns, or the fact that bariatric surgery was rapidly growing into bariatric surgery. So many of us who are more senior surgeons did not actually complete or attend a bariatric fellowship. And even now, if somebody wanted to do bariatric surgery, basically they could attend a course, they could start doing cases in a proctored environment or with a more senior partner. And once they achieved certain case numbers, they could get credentialed by their institution to be able to perform bariatric surgery. So the way this works is each institution has credentialing requirements, and the credentialing requirements are what determine what you can or cannot practice in that hospital. And each hospital sets its own credentialing requirements, which, sometimes if they really need a service, they can make those credentialing requirements more flexible or less restrictive. Whereas, in a big city where they might not necessarily require that service, they'll be more restrictive with their credentialing requirements. So really, it depends on the hospital as to what they allow or don't allow. Now, once this becomes more of a American Board of Surgery added qualification, etc., there's likely going to be a move to where, credentialing boards are going to require you to have had that type of certification for you to kind of get the checkbox that you can practice in that hospital. We are not at that stage yet.
Yeah, thank you.
All right.
Sudan, that was an excellent presentation, and yeah, it is great to see you again in this pandemic. So thanks to Charles. In this COVID-19 era, we have seen a decrease in the numbers of cases, as well as there is a kind of inability to let our fellows operate because we are wearing a lot of PPE, and it's very difficult to communicate. It's difficult to stand there for more than a certain time. So how are you tackling this, and have you increased the training duration, or are you thinking on the lines of increasing the duration of fellowship so that the requisite exposure is done?
Yeah, so that's a very, very good question, because this not only affects bariatric fellows, but it affects pretty much trainees in every specialty. And about 3 weeks ago, I attended a meeting where all of the board representatives, like the American Board of Surgery, Gynecology, Orthopedics, Neurosurgery, everyone was there and discussing this problem. And so it is a real problem where people are likely going to graduate with a reduced amount of experience, because many people in some specialties, the last 3-4 months, particularly like in a bariatric surgery fellowship, where it's only a 1-year fellowship, you acquire a lot of your experience towards the end of your fellowship. So there's the concern that people will likely graduate. Now, because of the extreme circumstances, we are not increasing the duration, but we are being very cautious in saying it's up to the program director to certify whether this individual is indeed capable of going out on their own or not. And even if they go out on their own, it's probably recommended that they work with a more senior partner or have, some kind of a safety network set up, because they might not have achieved those kind of milestones. Now, as you know, Charles and you and a lot of the people who are present have actually seen our system. We let our fellows operate from day one. And so we think for the most part, our fellows in our particular institution are going to be quite capable. But just yesterday, I was operating with one of our fellows, and she was doing her first Roux-en-Y gastric bypass using an EEA stapler with me, which by this time they would be able to do it pretty much on their own. So yeah, I think it's really affecting the training of our fellows.
All right, thank you so much, Dr. Sudan. Yeah, thank you so much, Dr. Sudan. So Dr. Shower and Dr. Sudan are both online. If anybody have any questions, can type your questions on the Zoom. They can answer your questions. So we move to next speaker, Dr. Mengyi Li. She is my colleague in Beijing Friendship Hospital. She's our data manager for our database, and going to talk about metabolic and bariatric surgery data management, lesson learned from Greater China metabolic and data and the bariatric database. Please, Mengyi Li.
Thank you, Charles. Hello, everyone. It's my great honor to be here in this great video conference. Thank you very much for Professor Shower and Professor Sudan for sharing with us about clinical research and professional training in metabolic and bariatric surgery. I'm listening carefully, taking the notes, and learning a lot. I'm really happy to share with you about data management lessons from Greater China metabolic and bariatric surgery database. And we are looking forward to embracing sincere suggestions from all of you. I'm a research doctor from Beijing Friendship Hospital, Capital Medical University. My name is Li Mengyi. Some people said that the obesity began in 1980s, but evidence shows that human obesity was first discovered in primitive works of art, dating back to the Paleolithic age. 2,500 years ago, Hippocrates said that sudden death is more common in those who are naturally fat than lean. Obesity is a long history. Its harm is obvious. According to the Global Obesity Report, a steady increase in obesity rates in all countries until at least 2030. Please note that although only 7% of individuals with obesity in China, the total national population accounts for 21% of the world. Obesity epidemic in China without a terminator. This is a survey based on 22 countries, including 75% of global procedures. The proportion of the number of patients who met the indication of metabolic and bariatric surgery and received this procedure is less than 0.01% in China, the lowest rate in the world. Surgical treatment in China, only the tip of the iceberg. Faced with the overwhelming trend of obesity, epidemic, and the minimal impact of surgical treatment, data collection provides us with a vital component in monitoring and evaluating our response to this epidemic. GCMBD is the first national database in China. This database is just like a growing boy. It was born in January 2018. At the beginning, it covered 7 main provinces in north part of China. In this area, the prevalence of obesity is much higher. The first edition of Registry Report 2018 was officially launched at the end of that year. In March 2019, the database system was upgraded to a newer version, and a growing number of centers are keen to join in this database, not only the north part of China. Therefore, the database has emerged to become a national registry system. The second edition of Registry Report was officially launched in March this year. So this is the framework of this database, including 5 main parts, and we hope it will be continuous optimization in the following aspects. So for a database, quality improvement is the foundation and always the hot topic. Big data is more than the data. This year, we will pay attention to the quality improvement programs. So we want to briefly share with you about 5 aspects based on our own center experience. So part 1, the quality of clinical practice determines the quality of data sources. So therefore, in order to ensure the homogeneity of clinical practice, standardization should be achieved in both pre-operative assessment and surgical operation. So Chinese College of Metabolic and Bariatric Surgeons is a national academic organization affiliated to National Health Commission. It focuses on training, accreditation, and quality improvement in metabolic and bariatric surgery in China. So number 2, data collection is the first step to start clinical research. In order to ensure the quality of clinical information collection, we have designed a clinical information form, which is filled out and signed by our case nurses and surgeons. Just the 2 pieces of paper. Based on this, combined with clinical system in our hospital, we complete CRF. This collection process is summarized by ourselves in order to record in time to avoid retrospective filling, to integrate data collection into clinical work, and the tabular design is consistent with our database. So number 3, data entry is an important step. At present, in our center, following 7 steps, division of labor, and then back-to-back for data entry for each case, and then data verification, and then to step 4 trace to the source data, and step 5 is modification, the error data. From step 1 to step 5 is a recycle. So if we want to use the data in our database, we should lock the data, and according to our protocol to do statistical analysis. Number 4, post-operative follow-ups plays very important role in metabolic surgery. So therefore, we pay attention to the cultivation of awareness of our patients' follow-up and the management of information follow-ups. And the next one, the last one, traceability of source data. This step is very important, including subjects coding table is very important, and operative videos, his systems, informed consent. All of these are the basement in the whole process. So registry charter is also indispensable in the whole process. We focus on the following 3 points: independent center account and the center all achievements sharing principles, and quality improvements key points, including data integrity, traceability, and stability. So this is a nice video of GCMBD registry report last year. Very nice to share with you. Let's have a general overview of it. So let's restart to share my screen. Sorry.
为了推动跨地区数据平台建设，为我国减重与代谢外科发展提供循证依据，并推进学科质量控制和有序健康发展。2019年3月，大华北减重与代谢手术临床资料数据库完成首次升级改版，且参与数据登记地区范围持续扩大。本年报为第2版减重与代谢手术2019年度临床数据分析报告。目前，数据库共开设中心账号52家，覆盖21个省市自治区，来自19个地区，38家中心提供共计2259例减重与代谢手术临床数据信息。基于有效数据集进行数据完整性分析，总体来讲，85%的中心数据完整性大于80%。基于整体有效数据，患者年龄中位数为31岁，其中女性患者占比73%，男性患者占比27%。其中女性患者群体 BMI 中位数为36.5千克每平方米，男性患者群体 BMI 中位数为41.5千克每平方米。在本年度有效数据中，各地区以籍贯、居住地为本地患者为主。28%的患者术前存在2型糖尿病病史，15%的患者术前存在高血压病史，51%的患者术前存在呼吸睡眠暂停综合征病史，包括轻度、中度及重度。18%的女性患者术前存在多囊卵巢综合征病史，43%的患者术前存在血脂异常，63%的患者术前存在高尿酸血症，12%的患者术前存在胃食管反流病，54%的患者术前幽门螺杆菌筛查阳性，1%的患者术前存在下肢静脉血栓，90%的患者术前腹部超声提示脂肪肝，8%的患者术前存在胆囊结石。本年度有效数据中，腹腔镜胃袖状切除术占82%，腹腔镜 Roux-en-Y 胃旁路术占8%，腹腔镜胃袖状切除联合空肠旁路术占7%，单吻合口胃旁路术占2%，腹腔镜胃袖状切除联合盼氏12指肠空肠旁路术占0.2%，腹腔镜胃袖状切除联合 Roux-en-Y 12指肠空肠旁路术占0.1%，其他手术方式占0.7%，修正手术占比1%，分布在6个地区。随访率等于随访例数比应接受随访例数，以手术日期为准进行随访日期的推算。63%的中心进行术后随访数据的录入。至此，大华北减重与代谢手术临床资料数据库正式升级为大中华减重与代谢手术数据库。
Okay, so this is a short, nice video of GCMBD of the registry report last year. So what we will do this year, we will continue to launch registry report each year, just like we do this year. And we will focus on follow-up study among excellent centers in our database. And we will encourage centers to do clinical research on our database and provide necessary fundings. So this is a mind map of clinical practice, training, data, and research. Just like a tree, they are correlated to each other. Just as we know, better data, better research. And for high-hanging fruits in our center, there are the following three studies. That is, we are doing and we are going to do. The first one is our OAGB versus room-wide bypass for diabetes remission, a retrospective multi-center superiority randomized trial. We call it older trial. The primary outcome of this study is the proportion of the patients with the HbA1c if less than 6% and without diabetes medication at 1 year after surgery. Oh, I'm sorry. So the second study will focus on efficacy of bariatric surgery for non-alcoholic fatty liver disease in individuals with obesity. It's a prospective multi-center follow-up study. And the primary outcome is the proportion of the patients with liver fat fraction if less than 5% by MRI at 1 year after surgery. And the liver pathological changes before and after surgery as a secondary outcome in this study. And this study is not on RCT design. So there are three aims of this study. First one, to demonstrate the efficacy of bariatric surgery for NAFLD. Secondly, to explore the curative, in fact, the differences among different types of surgery. And thirdly, to determine a predictive model for efficacy of surgery for NAFLD. We wanted to, based on this result, to further do RCT design to generate or to test the hypothesis based on the different types of surgery for NAFLD. And the third one is evaluation of the intragastric balloon system for individuals with obesity. It's also a prospective multi-center study. And the primary outcome is the proportion of patients with percent total weight loss if more than 5% at 16 weeks after surgery. So this is the first independent production in intragastric balloon in China. So indeed, data entry or data registry is a long way. So we should together, everyone achieves more. Our ultimate is to benefit our patients. So data entry registry is a tough way also. So, but I think with your mind, you may get it correct, but with your heart, you can make it perfect. I sincerely thank all of you. Thank you for your attention. Thank you.
All right, thank you so much, Dr. Li. And Vivek, have any comments?
Yeah, I think it's a wonderful initiative to have this kind of a registry. It's an absolute must, as Dr. Schauer also mentioned, for any kind of good research. And we also started with our registry in Obesity Surgery Society of India. It has been 3 years that it has been on, and we have been incorporating data. There are a lot of initial hiccups which you need to take care. It's a lot of effort, and I congratulate you for taking this and doing all this stuff. Is there a funding agency who is supporting you in this registry, or how are you funding it?
Okay, thank you for your question. This database is funded by ourselves, by our research foundation. So the foundation is also a big issue in China because it also takes much money. But because our leader, Professor Zhongtao Zhang, we have many research foundation by our government, so we can put some foundation into this database.
All right.
Yeah, it's from research funding, yes. Grant money. How about Dr. Stephen Yao?
Hello.
Hi.
Hi.
This database is different from the formal database in China because we have not only the number of patients and the operating ways and the BMI and the gender is including a lot of new character. So we think this is the new beginning for our China bariatric surgery database. I think it will help us to have a good start and a good future in the bariatric surgery.
Thank you, Professor Yao. Thank you for the suggestion. And as you say, that database data registry is a tough way also. So it's just a beginning. We have a long way to go, and we have to overcome many difficulties in China. So I sincerely hope to listen some suggestions from all of you to the data registry. Thank you.
Dr. Neto, do you have any suggestions to our national registry?
Yeah, I congratulate your big effort for establishing such a registry system. Well, actually, in Japan also, we also have that national clinical database, which is not especially for the bariatric surgery, but also for any kind of the surgery. So in terms of the registry for the bariatric surgery, well, the parameters is not enough in the national clinical database. So how many parameters do you have in your registry system?
Thank you for your question. Now we have 430 parameters.
430, wow.
Yeah, including baseline and follow-up.
Wow. So who does the, the data installation, the registry? The secretary? Secretary does the data input to the registry?
In each center of metabolic bariatric surgery in China, we have most of one team in each center, and we have case nurses in many centers in China now. So this job may be the case nurses.
It's big effort, right?
Yes.
Congratulations anyway. Thank you.
Thank you.
All right, so Dr. Shower is still here. So Dr. Shower, do you have any comments on this database, and what we're going to do? What can we do to do some research, high quality research from this database?
Yeah, no, I commend your efforts to establish, a registry. It's very difficult to do that, and I do think in the U.S. establishing our national registry, the MBSA QUIP, was fundamental to advancing the field in the United States. First of all, it allowed us to track our outcomes, particularly our complications. Yes. And we've been able to show over 10 years, a dramatic reduction in morbidity and mortality for bariatric surgery. And a registry is a good way to do that. But they're challenging, they're expensive, and they require lots of time and effort.
Yes.
And I would encourage you to, establish a good infrastructure at the beginning, particularly regarding your quality assurance. For example, in the United States, each center is required to submit all of their data, you see. And it's very important that that the integrity of the data, is good, and that the process for collecting the data and uploading the data to the registry is systematic and the same in all the centers. And then there needs to be periodic assessment of each center to cross-check to make sure that what they're submitting, is accurate and reliable. So this sometimes requires a site visit, which is not inexpensive. So all of those infrastructures need to be put in place, because the one thing that's actually worse than having no registry is to have bad data. Bad data is worse than no data, okay?
Yes.
Make false inferences, right?
Yes.
So it's important to take the time and effort to build it correctly. One of the most challenging aspects, and even to this day with the US database, is the follow-up. Obtaining short-term outcomes, which is essentially, complications, complications that occur in 90 days or, in the first 3 months. That's fairly reliable, but the challenge is obtaining longer follow-up on patients. So, 1 year, 2 year, 5 year data. At least in the US, it's much more difficult to get patients to come back to the center to report their long-term data. But this is critically important for bariatric surgery, because the outcomes for disease, chronic disease, is really dependent upon, not just the measurement, but the durability of the outcome. So you have to have good long-term follow-up. So anyway, I do commend you for this important task, and good luck.
Thank you, Professor Schauer. Just as you see that I know about and learn about MBS Equip, and just as you see, outcome is very important in bariatric surgery, and follow-up is also a difficult thing in China. So what we want to do to further do this year is to cultivate the awareness of quality improvement in each center, and based on this, we want to choose some excellent centers, and we want to pay some independent person to check and put to data entering the data into the database. We wish we have good luck. Thank you.
Yes.
All right.
Yes.
I think a very nice points put forward by Professor Schauer, especially the integrity of data and the process of entering the data, because I think they are kind of the Achilles heel, and to have the data process of entry and the integrity of data monitored is a difficult task, but it's a very important one.
Yes. So in each year in our registry report, we report the data integrity in our report, and the limit is more than 80%. But as you see, it's also another problem in our data. So we will do some quality improvement measures to improve that. Thank you.
All right, let's spend about 5 minutes to take any questions from our audience. Does anyone have questions for our panelists? All right, I see my friend Dr. Liu Shaozhang is here. Are you still here?
Yes, Charles, I'm here.
Yeah. So Dr. Liu is a very strong academic bariatric surgeon. He had a lot of publications on the SORD and the obesity surgery. So do you have any comments or questions for our panelists?
Yes, I just so what Meng Yi said about our database, and I'm interested. I'm interested in the NAFLD trial. Can you give more details about that?
Thank you, Professor Liu. Yeah, yes, we focus on this study that is efficacy of bariatric surgery for NAFLD in individuals with obesity. That is prospective, multi-center, and a follow-up study that is one arm. And the type of surgery includes 3 LSG sleeve, room-wide bypass, and LOAGB. And for the primary outcome is at 1 year after surgery, and the whole process is last 2 years. And now we have 4 centers in Beijing and 2 centers in Shanghai. And the total patients based on our sample size is 150 patients. Yes, and the primary outcome is liver fat fraction by MRI, and we also collect liver pathology
Yeah.
at before surgery and at 1 year after surgery.
Yeah.
As a secondary outcome, yes, because of the difficulties of follow-ups in China. Yeah.
Okay, thank you.
All right, so have any question for Dr. Schauer, Dr. Liu?
Yes, and I saw you and Dr. Schauer just talked about the clinical trial about PCOS. Yeah, I'm very interested in that career area. And as you know, I'm preparing for the trial about the sleeve for obese PCOS. And Dr. Schauer, I have a question. What do you think is a better comparative treatment, just a dietary treatment or medical treatment, a medicine or medicine?
Okay, so I think the question was about a PCOS study.
Yeah.
And what is the best comparator group, the control group, right? Yeah. So, you know, with PCOS, and I've done a little work in this area too. I published, and I was in Pittsburgh. This was more than 20 years ago. Our results, which was basically a case series of patients with PCOS who had Roux-en-Y gastric bypass. And, you know, it showed fairly significant results in terms of, you know, reducing not only weight, but some of the features of PCOS, such as irregular menstrual periods, infertility, and hirsutism, you know, unwanted hair growth, you know. And so I think it's a very valid area of investigation. Now, the medical treatment, my understanding of the medical treatment is not so good. You know, weight loss has been shown to improve PCOS. So I think including some type of weight loss, you know, dietary, exercise type of weight loss would be important. But some of the other treatments, hormonal treatments, you know, I'm not so familiar with in terms of, you know, their overall efficacy. The best thing for PCOS so far is weight loss.
Yeah. Okay, thank you. Thank
Great.
you.
I also see my friend Wai Yang and Liu Teng, Dr. Barry Xing, and Dr. Han Jianli. Do you guys have any comments or questions?
Hi, Charles.
Hi, Dr. Yang.
Okay, hi, Professor Zhang, Charles, and Dr. Meng Yi, and also Philip and Taseki. How are you doing? And this is a very, very great webinar organized by Professor Zhang's team. And for the national database and other multi-center studies, I think it's very important in Asian countries, especially in mainland China. The number of cases is very large, but we still lacking, still need some more evidence-based clinical study to show our data to our friends from other countries. So I'm looking forward to seeing our Chinese data in the near future. I looking forward also to seeing Philip's and other friends offline in the near future. So that's what I want to say. Thank you.
Great, thank you. So how about Dr. Barry Xiang and Dr. Han Jianli, Dr. Liu Teng? All right, so so it's almost 2 hours now, and I thank you everybody for this great webinar. Now I invite Dr. Zhongtao Zhang to give us closing remarks, and then we can conclude our webinar tonight. Dr. Zhang, please.
Okay. Thank you, everyone, including our panelists and all the audience, for staying with this webinar. Today's webinar is very informative and successful. It's a great webinar. Research and education are two essential components in metabolic and bariatric surgery. And clinical data collection provides us with solid foundation in providing better evidence-based care to our patients. As bariatric surgeons, we should always think about research, training, and high-quality clinical services in our daily work, not only for you and your program's success, but also for the benefits of our patients. Thank you very much again. Wish everyone successful in your career development. Please stay healthy and stay safe. See you soon again. Thank you.
Thank you. Thank you.
Thank you.
Everybody turn on the camera. We can take a group picture. Yeah. Everybody turn on the camera, please.
Please.
Zoom group picture.
Yeah.
Okay, please turn on the video.
Thank you so much for cancer healthy care.
All right.
1, 2, 3.
Thank you, Professor Zhang.
Thank you, my friend.
Thank you for all. Bye-bye.
Thank you.
Thank you.
All right.
Thank
See
you,
you
Dr.
next time.
Thank you very much.
谢谢。
Yeah. Good night. Have a good day.
谢谢郭处。
谢谢张院，再见。
谢谢。
再见。
Thank you very much. Thank you.
Thank you, Professor Zhang.
大家都依依不舍啊。拜拜。
拜拜。
拜拜。
晚安。
都不退，都想看。